Hello and welcome to Lecture 2 for Dental Local Anesthesia. I'm Dr. Varela, and today we'll be talking about the pharmacology of local anesthetics and vasoconstrictors. First off, I want to apologize if you happen to hear any noise in the background. That's probably my kids, and I apologize for that in advance. Just as a quick recap, though, from our last lecture, we talked about the theory of pain, and we continued to discuss the topic of pain and also patient assessment as it relates to evaluating a patient's ability to tolerate local anesthetics. When we finished the lecture, we finished off with neurophysiology and specifically focused on action potentials and how they occur. We're going to start our discussion on the pharmacology of local anesthetics and vasoconstrictors by going over two theories that propose to show how local anesthetics work. The first of the two theories is known as the membrane expansion theory. And this theory really just kind of states that the local anesthetic diffuses into the middle of the membrane. It starts to accumulate. It makes the area more bulky, and it causes the sodium channels to become misshapen, preventing the passage of sodium ions into the nerve. There's not a lot of evidence to support that, and really I'm just mentioning it in passing, and it's not really going to be important at all. The second theory is a little bit more popular, and it's known as the specific receptor theory, and it states that these local anesthetics bind to specific receptor sites on the sodium channels that are usually occupied by calcium ions. Now, there are some studies that give support to this theory or some variation of it, so we'll look at this theory as kind of the working theory as we move forward with our discussion. Now, just as a side note and somewhat on an unrelated note, you should know that the density of sodium channels in myelinated nerves is much higher than in unmyelinated nerves. Now, typically, the highest concentrations can be found in the nodes of Ranvier of myelinated nerves, and the concentration is usually as high as 20,000 per micrometer. Like I said just a minute ago, the specific receptor theory depends on this idea that calcium ions being displaced by a local anesthetic molecule from the receptor site on the sodium channel eventually leads to what we call a conduction blockade. And one of the proposed mechanisms by which this conduction blockade occurs, it happens as follows, and you can follow along with me here on this side of the slide. First, the bound calcium ions are displaced from the sodium channel receptor sites by the local anesthetic molecule. And then the molecule of local anesthetic then binds to that site and allows the local anesthetic to essentially change the shape of the sodium channel. The sodium channel essentially blocks the entry of sodium into the nerve cell, which essentially decreases that influx of sodium ions that we talked about during the phase of depolarization, essentially eliminating that whole process of depolarization and thus kind of blocking that threshold potential from ever occurring. So essentially what you get is a lack of development of an action potential. And that's what we call a conduction blockade. So as a quick review, we have calcium ions that are normally at this receptor site. They get dislodged by local anesthetic, which then binds to the site. The local anesthetic, in essence, blocks the entry of sodium ions and essentially keeps an action potential from happening. And that's what we call a conduction blockade. Now, it's important to note that the nerve membrane remains in a polarized state because the ionic movements that are responsible for the action potential never really develop. The nerve blocks produced by local anesthetics are known as non-depolarizing nerve blocks. It's also really interesting to note that, in the tissue, we also have other ions. We have potassium and calcium and chloride ions. And really, the local anesthetic has really no bearing on any of those other ions. It's really focused on the movement or the lack thereof of sodium ions. So now that we have a running theory of how local anesthetics work, let's take a step back and talk a little bit more about some of the desirable characteristics that we want in a local anesthetic. First, a good local anesthetic has to be non-irritating to the tissues it's applied to. It shouldn't cause any damage or as minimal damage as possible. It shouldn't permanently alter the physical structure of the nerves it contacts. It should have a very low potential for toxicity. It should be really, really effective regardless whether it's injected or topically applied. It should have as short of an onset as possible, and the duration of action should be long enough to allow you to finish your procedure without really requiring the patient to go through this extended recovery period. Most local anesthetics meet the first two criteria, but not necessarily the rest of the criteria. And we'll talk about those in more detail later on in the semester. Now, local anesthetics are composed of three basic parts, and we're talking about on a molecular level. First is the lipophilic part, an intermediate chain, and then a hydrophilic part. The fact that both a lipophilic and hydrophilic part are present in this molecule makes this molecule an amphipathic molecule. Now, the largest part of the molecule is composed of an aromatic structure, and you can see that right here on both of these. This aromatic structure is usually derived from a benzoic acid, an aniline, or a thiophene, and that's what really comprises that lipophilic part. The intermediate chain right here and right here is where you can identify the type of linkage that's present in the molecule, either an ester or an amide. This becomes important when we start to talk about how these molecules are metabolized. Esters are metabolized through a process known as hydrolysis, while amides are not. Now, moving to the terminal portion of this molecule, we have the hydrophilic part, which is derived either from acetic acid or an ethyl alcohol. Now, as a side note, some local anesthetics, such as benzocaine, don't have a hydrophilic part and are really not suitable for injection, but they actually do work really well as a topical anesthetic. Now, from the standpoint of pH, local anesthetics are basic compounds that are poorly soluble in water and very unstable when they're exposed to free air. Their pK values typically range between 7.5 to 10, and in this basic form, they have little to no clinical value. To make local anesthetics usable, manufacturers usually combine them with acids to form anesthetic salts. Now, this makes them water-soluble and more stable. And you can see evidence of this on the side of the carpule here, where it says lidocaine HCl, and that's the hydrochloric acid there that they combine so that it makes the local anesthetic more water-soluble. Now that they're water-soluble, they can be combined with sterilized water or saline as a carrier. Now, once in solution, local anesthetic molecules exist simultaneously in two different forms. The first as an uncharged molecule represented by the Rn or free base form. The second is a positively charged molecule, which is represented by the RNH plus or cation form. Now, the relative proportions of each form really varies with the pH of the surrounding environment. In a high pH or basic environment, the equilibrium shifts towards the base form. And so you have the base form here in a high pH basic environment. In a low pH or acidic environment, the equilibrium really shifts to the left, and the most of the anesthetic solution is in the cation form or RNH plus form. This is important to know really because the local anesthetic can only diffuse through the nerve sheath to elicit its action if it's in its free base form or the RN form. As I mentioned before, the proportion of free base that's available is really dependent on the pH of the environment. So, let me give you kind of an example of this process. So here we have the extracellular environment, the nerve sheath, and then we have the intracellular environment. Now let's say that the extracellular environment has a pH of 7.4, which is the pH of healthy human tissue. Now, for simplicity's sake, let's say we have 1,000 molecules of local anesthetic that are injected into this environment. Under these conditions, at a tissue pH of 7.4, the local anesthetic will be present in the following proportions. RNH plus will be at 75% and RN will be at 25%. This means that of the 1,000 molecules, 750 of them will be in the cationic form and 250 will be in this free base form. Now, of all of these molecules, all of the 250 RN or free base form molecules will diffuse through the nerve sheath and into the nerve cell. And when this happens, the equilibrium that once existed outside the nerve cell now has been disrupted. Those 750 cations now have to find a new equilibrium, which remember is determined by the pH of the tissue. The same proportions of 25% base form and 75% cation form still exist. So of the 750 molecules of cation form remaining, the new equilibrium will shift to create 180 free base molecules, all of which will diffuse into the nerve sheath, and that's what this is showing here on this slide. Now, this process really sounds good and everything in theory, but realistically, not all of the molecules are going to make it into the cell because of the process of diffusion. In other words, the local anesthetic molecules will try to move in every possible direction, not just into the nerve cell. And this becomes important when we talk about the idea of systemic toxicity due to the diffusion of these local anesthetic molecules into the bloodstream. So what happens to the molecules once they have entered into the nerve cell? Well, because the pH inside the nerve cell is also 7.4, those molecules that have entered try to find a new equilibrium as well. And the same proportions exist inside as they do outside. 25% of them will go in their free base form and 75% will go in the cation form. Now here's the interesting part. The cation or RNH plus form is the one that then binds to the sodium channel receptor site, which then initiates that whole conduction blockade that we talked about. And so no sodium can get into the nerve. Now let's take a step back and look at this. Here we have a process by which local anesthetics can diffuse into a nerve cell to produce a conduction blockade. Now, this process is dictated by the pH of the surrounding environment, which is healthy tissues. It's relatively basic, 7.4. But what happens to this process when the pH is lower and more acidic? What causes tissues to take on a more acidic pH? Now, tissues can become more acidic when an infection is present. Now, you'll remember from the previous slide that that a lower pH causes the equilibrium to shift to the left, producing more cationic forms of the molecule. Since these cationic forms can't diffuse into the nerve, the local anesthetic essentially becomes ineffective. From a clinical standpoint, this explains why patients with an infection or an abscess are really hard to get numb. But let's look at this type of a situation a little more closely. Let's say the pH of infected tissue is around 6. And let's say, for the sake of simplicity, that we are dealing with 1,000 molecules again of local anesthetic. At this tissue pH, approximately 99% of the molecules are present in their RNH plus or cation form. That would mean that only 10 of these 1,000 molecules are in their RN or free base form of the molecule. And only 10 of them are available to diffuse through the nerve cell. Realistically, like I said before, it's a little bit less than that, but for simplicity's sake, let's assume that all 10 make it into the nerve. The ones that reach inside shift to the same proportions as before. 75% of them shift to their cationic form and 25% to the base form. And the process continues. Now, due to the smaller proportion of base form molecules that reach the inside of the nerve, the blockage produced is inadequate to provide any measurable clinical outcome. So, in other words, again, the patient never really achieves anesthesia. Now, one last comment about pH. Most local anesthetics without a vasoconstrictor have a pH between 5.5 and 7. Because the tissue has this really massive capacity to buffer solutions um, that are not normally at a normal pH of 7.4, the tissue is able to buffer these solutions back to a normal pH. But in doing so, it really shortens their duration of action. They're not as effective. On the other hand, local anesthetics with vasoconstrictor have a chemical called sodium metabisulfite that's added to them to retard the oxidation of the vasoconstrictor. An added bonus to this is that it makes the solution more acidic, which then in turn prolongs the effectiveness of the local anesthetic molecule. A quick word about mucous membranes is that mucous membranes really in and of themselves are terrible at buffering solutions. So you can actually apply local anesthetic topically and it will be effective for a relatively long period of time, which is why we use topical anesthetics such as benzocaine on the mucous membranes prior to injecting local anesthetic into the tissues. Benzocaine is not affected by pH because it's not readily ionizable. So the fact that the mucous membranes are not able to buffer solutions is actually a good thing because benzocaine doesn't need to be ionized. In addition, because benzocaine is not soluble in water, it doesn't diffuse into the bloodstream, which makes it really safe compared to other local anesthetics. All right, question time. So what is the normal pH of tissue? 7.4. What is the pH of an inflamed area? We're going to say it's between 5 and 6. What's the primary, let's see, the primary action of local anesthetics in producing a conduction block is to decrease the permeability of ions, permeability of the ion channels to what ion? So that would be sodium ions. And question number 4, you may have missed because I said it pretty quickly. Local anesthetics are generally considered to be which of the following? And they're considered to be weak bases. So let's go over some terms here, which I think it's going to be really important for you to know these terms for the quiz. Now, the term pharmacokinetics describes the actions of the body on a particular drug. This includes its uptake, distribution, biotransformation, and elimination, which we're going to go through in the next few slides. Pharmacodynamics, on the other hand, is a term that's used to describe the actions of a drug on the body. So pharmacology includes both pharmacokinetics and pharmacodynamics. Now, the process of uptake is also sometimes known as absorption. The rate and efficiency of absorption is really kind of dictated by the route of administration. And it makes sense if you think about it. So stop and think about it for a second, and I'll give you an example. Topically applied drugs may take a much longer time to get into the bloodstream than would drugs that are actually introduced intravenously, right? And so the uptake really kind of depends on the mode of administration or the route of administration. So let's go over a few different types of or routes of administration. First, there's GI or gastrointestinal, which would include medications that are absorbed in the gut. Think pills, capsules, tablets, and so forth. Then you have orally administered, which would include medications that are absorbed through the mucosa in the mouth. Think nitroglycerin or Oragel. Then you have intramuscular, which for our purposes include dental injections. You have intravenous, which would include the majority of the intravenously administered sedatives. Subcutaneous, which would include drugs such as insulin and some forms of morphine. and topical, which for our purpose we'll refer to as a cutaneously administered drug like topical lidocaine or for cutaneous burns or even nicotine patches. Now, when local anesthetics are injected into soft tissues, they exert a degree of vasoactivity on local blood vessels. Most local anesthetics produce vasodilation to differing degrees, and the degree of vasodilation really kind of depends on which type of local anesthetic you're talking about. For example, amide local anesthetics are considered to be relative vasodilators, while esters are really potent vasodilators. Now here's a boards question for you, and I know the boards have changed a little bit, but here we go. Which local anesthetic is the most potent vasodilator, and what is it used for? So the answer to that would be procaine. Procaine is the most potent vasodilator among local anesthetics, and is occasionally used in clinical settings to induce vasodilation when, for example, you may have introduced epinephrine or some other vasoconstrictor into the bloodstream. So it's used to kind of counteract that. Now, this can happen in a clinical setting for dentists as well, when we have a situation where the local anesthetic accidentally gets injected into the bloodstream, or we also call it intravascular injection. You might be asking yourself, well, why is that bad? I mean, why is it bad if I inject the local anesthetic directly into the bloodstream? Isn't that what we want? And the answer is no. We don't want that local anesthetic to go into the blood because it's carrying a lot of different agents that have different clinical activities. We really just want to use the local anesthetic to localize the effect at the site of injection. Now, intraarterial injections of local anesthetics may produce overdose effects just as rapidly as if you were to just put them right into the cardiovascular system. And some things that you might notice in your patient if this does occur is that they might start getting some confusion, slurred speech, muscle twitching, elevated blood pressure and pulse, seizures, CNS depression, headaches, dizziness, blurred vision, ringing in the ears, drowsiness, numbness, or unconsciousness. Um, and I said that kind of fast, but really just think of the CNS things that might happen if a patient were to undergo some sort of toxic event that made it to the central nervous system. Now, intraarterial injections should be a rare occurrence, but unfortunately they do happen, and they happen all too often to dental providers who are often not being careful about what they're doing, about their technique, and are just not paying attention. So these are what I like to call iatrogenic misadventures, and they occur most often in areas where you're doing a regional block as opposed to a local infiltration. And one example of that would be it occurs when you're doing an inferior alveolar nerve block or a posterior superior alveolar nerve block. And I'll explain a little bit more about that in just a moment. Now, at the opposite end of the spectrum of vasoactivity, we have an anesthetic drugs such as cocaine. Now, believe it or not, cocaine used to be used as an anesthetic, but it's not used as an anesthetic anymore because it's a very powerful vasoconstrictor. Initially, cocaine does elicit some vasodilatory activity, but it really just produces a very strong and consistent vasoconstriction afterwards. And it's very intense and prolonged. An interesting tidbit of information is that when you have a person who's using cocaine, a heavy cocaine user that snorts it through their nose, you can have this constant vasoconstriction that eventually leads to that tissue in between the septal tissue in between both sides of the nose basically undergo a process of hypoxia, and then eventually the tissue dies, and so then you have a perforated nasal septum that's caused by snorting cocaine. Now, getting back to vasoactivity, a significant clinical effect of vasodilation is an increase in the rate of absorption of the local anesthetic into the blood, and also a resultant decrease in the duration and quality of pain control. And that makes sense. The local anesthetic opens up the blood vessels, then enters the blood vessels, and now you don't have the local anesthetic at the site of injection anymore. It's somewhere in the bloodstream. Now, the rates at which the local anesthetic is absorbed into the bloodstream and reach their peak blood level varies according to the route of administration. The oral route is poorly absorbed except for cocaine. All local anesthetics are absorbed poorly, if at all, from the GI tract. Sorry about that. Where was I? So the oral route, again, is really, except for cocaine, of course, is really poorly absorbed. In addition, though, most of these undergo a hepatic first pass effect after oral administration. So if you'll remember from your earlier days in biology, first pass metabolism is basically where a drug is significantly metabolized in the liver before entering the cardiovascular system systemically, right? So that's the oral route of administration. Topical route is also variable, and local anesthetics are really absorbed at different rates depending on where you administer them and what type of mucous membrane they are located in. Now, once the drugs are absorbed, the drug is then distributed throughout the body, and this is the second step here in the process of the pharmacology of local anesthetics. And they go to the most highly perfused organs or areas of the body that have a lot of perfusion, such as the brain, the liver, the kidneys, the lungs, and the spleen, which initially have higher anesthetic blood levels than other parts of the body that are not as perfused. Now, by comparison, the largest tissue type or organ in the body is skeletal muscle, and that's something that you might want to remember for future testing. And this topic of perfusion becomes important when we talk about the potential for systemic toxicity of a drug. And the blood level of a local anesthetic is really influenced by a few factors. And you know, as I go through these, really think about how this would affect and increase the risk of systemic toxicity. First is the rate of cardiovascular absorption, and in other words, the rate at which it's actually entering the cardiovascular system. And once it's entered the cardiovascular system, what is its rate of distribution into the tissues? Which incidentally is more rapid in healthy patients than in those who have medically compromised conditions such as congestive heart failure. Elimination, how is it eliminated from the body? This really does influence this whole topic of systemic toxicity. If the drug is hanging around in your body for a really long time, it's going to continue to make its effects known. But if it's eliminated quickly and excreted through urine, then its effects are not going to last. Now, speaking of elimination, each drug has an associated elimination half-life. Now, simply put, an elimination half-life is the time necessary for a 50% reduction in blood level of the drug. Now, the number of half-lives of a drug are seen as follows. One half-life is 50% because 50% of 100 is 50. Two half-lives is 75% because 50% of 50 is 25. And 50 plus 25 is 75, and so forth. One last note, all local anesthetics readily cross the blood-brain barrier and the placenta, and which means that they cross into and enter the circulatory system of the brain and also of the fetus. really this becomes important because we start to see some of the same negative side effects of local anesthetic and systemic toxicity, the systemic toxicity of a local anesthetic in both highly perfused organs like the brain and also in fetuses, developing fetuses. Now, if you remember from a few slides ago, I said that there are two major groups of local anesthetics, the esters and amides. These two groups are differentiated not only by their bonds, but also by the way that they're metabolized. And this is the third step, biotransformation or metabolism. Now, ester local anesthetics are hydrolyzed in the plasma by the enzyme pseudocholinesterase, and they are hydrolyzed into a molecule known as para-aminobenzoic acid, or PABA. Now, patients with pseudocholinesterase inactivity conditions that don't allow them to hydrolyze by use of pseudocholinesterase are really unable to get rid of these esters. They're not able to detoxify their blood from these circulating esters at a normal rate. And for these type of patients, amide local anesthetics are recommended. Now, typically, we use more amide local anesthetics in dentistry, where in medicine, they use a lot more ester local anesthetics. Now, the rate of hydrolysis has an impact on the potential toxicity. For example, the faster an ester local anesthetic is hydrolyzed, the less toxic it is. The longer it takes to hydrolyze, the more toxic it is. Additionally, as mentioned before, the longer it takes for the drug to be excreted, the higher the potential for systemic toxicity as well. Now, on the flip side, amide local anesthetics undergo a complex process of dealkylation, and this occurs in the liver. And virtually entirely in the liver for most local anesthetics. Lidocaine, mepivocaine, bupivacaine, and etidocaine certainly fall into that category. Prilocaine, on the other hand, undergoes primary metabolism in the liver, with some additional metabolism occurring in the lungs. Articaine is a hybrid molecule that contains both ester and amide compounds and really undergoes metabolism in the blood and the liver. Under normal circumstances, about 70% of the injected local anesthetic undergoes hepatic metabolism, and this is considering that the patient has normal liver function. Now, with patients with compromised liver function, the rate of biotransformation is significantly lower. It's significantly decreased, which results in higher blood levels of the anesthetic, and that makes sense. This translates really into an increased risk of systemic toxicity. Now, the toxicity comes from the metabolites that are produced following biotransformation. These active metabolites possess significant clinical activity in and of themselves. I'm going to talk to you a little bit about an example that may also be on the boards, and that's of prilocaine and the condition methemoglobinemia. Now, prilocaine is a clinical example of this, and in and of itself, prilocaine doesn't produce methemoglobinemia, but orthotoluidine, which is an active metabolite of prilocaine, does induce the formation of methemoglobin, which in turn is responsible for methemoglobinemia. Now, a quick word about allergic reactions. Allergic reactions to amide-type local anesthetics are extremely rare, but patients can exhibit an allergic reaction to the methylparaben or other preservatives in the solution. And you can always tell that it's an allergic. You can always tell that it's an allergy to a component present in the solution because it usually presents with a very clinical presentation of an allergic reaction. So we're talking about urticaria or edema or something like that. Now, the final step in the pharmacological action of all these local anesthetics, as well as a factor that affects the potential for toxicity, as we've been talking about, is this topic of excretion, okay, or elimination. The kidneys are responsible largely for the excretory function and the elimination of local anesthetics and their metabolites. And as mentioned before, about 70% of an injected drug undergoes metabolism or biotransformation And some of the remaining percentage of a given dose is excreted completely unchanged in the urine. The percentage really varies greatly according to the drug. Uh, Patients with significant renal impairment may not be able to eliminate the parent local anesthetic or its metabolites from the blood, and this increases the potential for systemic toxicity. Now, significant renal disease represents a relative contraindication to administering local anesthetics, and this includes patients undergoing renal dialysis or someone that has chronic glomerulonephritis or pyelonephritis, which would make sense that they would be classified as an ASA class 4 or even a 5. So now that we've talked about this four-step process in the pharmacology of local anesthetics, we talked about uptake, absorption, distribution, metabolism, biotransformation, and excretion and elimination. Let's talk a little bit more in depth about the systemic actions of these local anesthetics. Now, we said before that local anesthetics reversibly block action potentials in all excitable membranes, not just nerve cells, but also myocardial cells and so forth. Now, this makes organ systems that are highly perfusible, such as the central nervous system and the cardiovascular system, particularly susceptible to their actions. Those actions greatly depend on the blood or plasma levels of the local anesthetics that exist in the organ that we're talking about. In other words, the higher the level of local anesthetic in the target organ, the greater will be the clinical action. So let's take a look at some of these specific effects on these systems. We know that local anesthetics readily cross the blood-brain barrier. Now, in general, the pharmacological action observed is CNS depression. Now, the clinical manifestations are somewhat different. For example, at lower blood levels that correspond to non-toxic therapeutic doses, no CNS effects of any clinical significance are noted. Convulsion, on the other hand, at higher blood levels can occur that correspond with toxic overdoses. And obviously, as I just said, the primary clinical manifestation is generalized tonic-clonic convulsions. Interestingly enough, though, some local anesthetics do demonstrate anticonvulsive properties, and this occurs at blood levels that are considerably lower than what would produce seizure activity. Local anesthetics can also produce a degree of analgesia when they're administered intravenously, and they do so by increasing the threshold for the propagation of a pain-related action potential. Another possible effect on the CNS is mood elevation, also known as euphoria. And this can be seen specifically with a drug such as cocaine. That's what brings people back, is that euphoria. Unfortunately, this particular substance is also prone to habituation, which with its myriad of side effects can also lead to death. One of the most common side effects of overdose is respiratory arrest. Now, the second major system that can be directly impacted by local anesthetics is the cardiovascular system. And local anesthetics have direct action on the myocardium. And the effect of local anesthetics on the myocardium is really similar to the effects that it produces on peripheral nerves. In the myocardium, it translates into decreased electrical excitability of the myocardium, decreased conduction rate, decreased force of contraction. And this really makes sense because if it is blocking a conduction of an action potential in nerves, it is probably going to be doing the same thing in myocardial tissue as well. Now, this particular effect can actually be beneficial in treating people that have various cardiac dysrhythmias. The foremost of these are lidocaine, which can be used for treating dysrhythmias, and so forth. Now, moving on to other parts of the cardiovascular system, we have the peripheral vasculature, and of the drugs considered local anesthetics, only cocaine consistently produces vasoconstriction. All other local anesthetics produce vasodilation through relaxation of smooth muscles in the walls of the blood vessels. This, of course, leads to increased blood flow to and from the site of injection, which then increases the rate of drug dispersal, which in turn decreases the depth and duration of local anesthetic action. Now, a quick word on the condition known as malignant hyperthermia. And this is a disorder in which a genetic variant alters an individual's response to certain drugs. Clinically, this may manifest itself in the form of tachycardia, tachypnea, unstable blood pressure, cyanosis, which is bluing of the skin, respiratory acidosis, fever, muscle rigidity, and death. Many of the commonly used anesthetics can trigger this in certain individuals. And this will be important later on as we discuss some of the things that you should go over with your patient. Now, let's take a break from this and give you a little scenario here. You're administering local anesthetic to a 27-year-old white male that weighs about 175 pounds. You previously performed a root canal on tooth number 2. It doesn't really matter whether it's number 2 or 15, but the tooth broke in half and it's no longer restorable. After reviewing your clinical findings with the patient, you recommend extraction. You start to give them a posterior superior alveolar nerve block, which, just for reference to this particular case, the posterior superior alveolar nerve block is posterior to tooth number 2. So it's going to be right behind the tooth right behind tooth number 2, essentially. And what we also have there, if you think about your head and neck anatomy, is we have a very large vascular structure, and it's called the pterygoid plexus. Okay, so keep those things in mind. Now, you administer the PSA block to get the tooth numb, and after you remove the needle and ask the patient how they're doing, they respond immediately with complaining of a headache, and the patient starts acting very anxious, and they appear to be a little bit confused. So the questions are: what is wrong with this patient? What evidence do you have to explain your suspicion? And how will you manage this situation to get the patient back into a healthy situation? So take a moment to think about that. You can pause the video if you'd like and take a moment to answer those 3 questions, and we'll be back with the answer. So back with the answer for these 3 questions: what is wrong with this patient? What evidence do you have to explain your suspicion? And how will you manage the situation? So the answer to the first question, taking into account that we are injecting posterior to tooth number 2 right around the tuberosity, and knowing that there's a very large vascular structure in that same area known as the pterygoid plexus, we may have a possible intra-arterial injection of local anesthetic. And this is really given evidence by the fact that the patient is confused, they're having a headache, and they're starting to feel a little anxious. The answer to question number 2, what evidence do you have? Same as what we just said before. You're giving a PSA which is adjacent to the maxillary tuberosity, which is also adjacent to this large vascular structure known as the pterygoid plexus, and the patient's symptoms are really what are setting off the red flags for you. Now, how will you manage this situation? You're going to stop the procedure, position the patient comfortably, and seek medical attention immediately. And so just keep that in mind, that you have to be situationally aware every time that you're administering local anesthesia. That concludes the first portion, which is pharmacology of local anesthetics. If you have any questions about the pharmacology of local anesthetics, please let me know. We're going to move on and talk about the pharmacology of vasoconstrictors. So we talked about how all local anesthetic drugs are inherently vasodilators, which has the potential to increase the distribution of the drug beyond the site of injection. And that can lead us to the increased risk for systemic toxicity. Vasoconstrictors, on the other hand, do the opposite. They constrict blood vessels, thus counteracting the native vasodilatory effects of local anesthetics. Now, this offers a lot of different benefits. First, by constricting the blood vessels, vasoconstrictors really limit the flow of blood in and around the site of injection. And this essentially keeps the local anesthetic localized to the site of injection. It also increases its effectiveness and duration of action. And it also provides the added benefit of hemostasis. Now, since the local anesthetic stays at the site of injection, it's less likely to be absorbed into the cardiovascular system, and that decreases its potential for reaching critical organs and causing toxic effects. Now, on a molecular level, the structure of vasoconstrictors is very similar to epinephrine and norepinephrine. Now, since epi and norepi are mediators of the sympathetic nervous system, vasoconstrictors are known as sympathomimetic drugs. Now, when sympathomimetic drugs have a hydroxyl group in the third and fourth position, as you see here, of the aromatic ring, they're known as catechols. Now, if they have also an amine group attached to the aliphatic side chain, they're called catecholamines. Now, there are three different categories of sympathomimetic amines: direct acting, indirect acting, and mixed. Direct acting exert action directly on the adrenergic receptors, and those include things like epinephrine, norepinephrine, and levonorepinephrine. Indirect acting release norepinephrine from the nerve terminal, which work to block the reuptake of sympathetic mediators, and that increases the concentration of those mediators in the synapse. Some of these sympathomimetic drugs include tyramine, amphetamine, methamphetamine, and so forth. And finally, we have mixed action sympathomimetic drugs, and it's exactly what it sounds like. They use both direct and indirect methods for exerting their effect on the receptors. And an example of those would be ephedrine. Now, these adrenergic receptors are found in most tissues of the body and can really be placed into two different categories: alpha receptors and beta receptors. And you know a lot more about this than what I'm going to teach you in this class, and we're just really going to touch on these things. Now, these two different categories are based on how the catecholamine affects smooth muscle. First, alpha receptors are responsible for contraction of smooth muscles around blood vessels, which is another term for vasoconstriction. Alpha-1 receptors, when they're activated, cause the contraction of smooth muscles around blood vessels, which lead to vasoconstriction. Alpha-2 receptors do quite the same thing. After they're activated, they also cause contraction of smooth muscles surrounding blood vessels, but they also provide a different function. They provide a function which essentially is a negative feedback. And the negative feedback serves to stop the release of additional catecholamines into the synapse. Now, the second type of receptor is a beta receptor, which for our purposes, when it's activated, is responsible for the relaxation of smooth muscle or dilation. And this can lead to either vasodilation or bronchodilation, depending on the type of beta receptors. And these beta receptors are also subdivided into beta 1 and beta 2 receptors. Now, beta 1 receptors are found in the heart and small intestines and are responsible for the cardiac cardiostimulation. Beta 2 receptors are found in the bronchi and vascular beds and uterus, and they produce bronchodilation and vasodilation. Now, a good way to remember this is by remembering that beta 1 really has its effects in the heart, and we only have one heart. Beta 2 has its main effects in the lungs, and we have two lungs. Another way to remember the difference between what alpha and beta receptors do is by following this convention. Alpha receptors constrict, and beta receptors dilate. A, B, C, D. So hopefully that helps you to remember and keep straight how these different receptors affect functions in the body. Now, vasoconstrictors are not added to local anesthetic solutions in their most potent form. They have to be diluted. The dilution of vasoconstrictors is often referred to as a ratio and is often written in the following manner. 1 to 1,000, or 1 to 1,000 can also be written as 1:1,000. Okay? Now, let's talk about what this means. So a concentration of 1 to 1,000 has 1 gram or 1,000 milligrams of drug in 1,000 milliliters of solution. And this is the same as 1,000 milligrams in 1,000 milliliters, or 1 milligram per milliliter. Now, in dentistry, when we talk about these concentrations, the concentrations of vasoconstrictors in a dental setting are much less concentrated. And this is to produce basically a more safe dilution of the vasoconstrictor. And to produce this more dilute concentration that is effective yet safe, the 1 to 1,000 dilution is processed in the following manner. You take 1 milliliter of a 1 to 1,000 solution and you add it to 9 milliliters of solvent or sterile water. Now, this produces a dilution of 1 to 10,000, which equals 0.1 milligrams per milliliter. We then take 1 milliliter of the 1 to 10,000 solution and add it to 9 milliliters of solvent or sterile water, and that produces a 1 to 100,000 concentration, which equals 0.01 milligrams per mil. Here's a chart that shows the clinical uses of different concentrations of vasoconstrictors, and you'll notice that the therapeutic concentrations for epinephrine in emergencies is 1 to 1,000, okay? And which is about 100 times more concentrated than what's normally used in dentistry. Now, believe it or not, although epinephrine is the most commonly used vasoconstrictor in both medicine and dentistry, it's not an ideal drug. Whatever benefit it renders really has to be weighed against the risks it carries, because just like any drug, if it's absorbed from the site of administration and is carried into the cardiovascular system, it can affect the cardiovascular system in different ways, such as affecting the cardiac output, the stroke volume, the blood pressure, and heart rate. Now, these effects are particularly important as it relates to patients with cardiovascular or thyroid diseases. Now, because even normal doses can produce significant clinical side effects in these patients, it's really important to know when you have a situation that a patient has these conditions, and when it's important to not use local anesthetics that have vasoconstrictors in them. Now, there are other vasoconstrictors other than epinephrine. We have norepinephrine, and it produces a much more intense vasoconstriction, which can actually lead to a dramatic increase in blood pressure. Its use in local anesthetics, especially in the United States, is really kind of diminishing, if not already dead, because of the severity of its side effects. And you should know that the mixture of epinephrine and norepinephrine is absolutely dangerous. Now, for this reason, epinephrine is really kind of the one that we use in local anesthetics for dentistry. So let's talk about epinephrine for a moment. Now, as was mentioned in the previous lecture, epinephrine is local anesthetics are made water soluble by an acidification process, and the same really kind of goes for epinephrine. Epinephrine also normally exists in a free base form, which requires it to be acidified to make it more water soluble. Now, the process of acidification of vasoconstrictor is a little different than the process for local anesthetic drugs. Now, because the vasoconstrictor is subject to oxidation by heat and the presence of heavy metal ions, a chemical called sodium metabisulfite is added to really kind of delay its deterioration. As a result, this acidifies the epinephrine and the solutions as a whole. Now, a little fun fact, having a sulfa allergy does not mean that the patient is allergic to the preservative sodium metabisulfite in local anesthetics. The two are not the same thing. Now, a local anesthetic containing epinephrine has a relatively shorter shelf life, around 18 months, when compared to a local anesthetic without epinephrine, which tends to be 36 months. Epinephrine can really be harvested from a couple of different sources. It can be harvested from the adrenal medulla of animals, which comprise 80% of the adrenal medullary secretions. But it can also, it also exists in both the levorotatory and dextrorotatory forms, with the levorotatory form being about 15 times more potent. It can also be created synthetically in a laboratory. Epinephrine directly acts on both alpha and beta adrenergic receptors, with beta effects being more predominant. And that's important to remember, that beta effects are more predominant. Now, the systemic actions of local anesthetics. Epi really stimulates beta-1 receptors in the myocardium, which increases cardiac output and heart rate. It also stimulates the beta-1 receptors in the pacemaker cells, which increases dysrhythmias, including ventricular tachycardias and PVCs, or premature ventricular contractions. It also produces dilation of the coronary arteries, which increases coronary artery blood flow. It also affects systolic blood pressure by increasing it. Diastolic blood pressure is decreased at small doses and increases with larger doses due to the beta-2 sensitivity to epinephrine. So really, the cardiovascular dynamics are as follows. We have the systolic and diastolic outputs are increased. The cardiac output is increased. Stroke volume is increased. Heart rate is increased. Strength of contraction is increased, and myocardial oxygen consumption is also increased. Now, cumulatively, these effects lead to a decrease in cardiovascular efficiency, and that makes sense, because if you've got the whole cardiovascular system out of whack, it's not going to be as efficient as it would be if everything was normal. Now, it doesn't really require that much epinephrine to cause the cardiovascular system to go out of whack. Really, the cardiovascular system responds with an increase in heart rate and systolic BP with only 2 carbules of local anesthetic containing epinephrine. And this is at a concentration of 1 to 100,000. Now, a word on hemostasis. In the clinic, we use the vasoconstrictive action of epinephrine to help provide hemostasis during surgical procedures. The hemostasis occurs because of the increased concentration of epinephrine, which stimulates alpha receptors. Now, this causes constriction of smooth muscles surrounding the blood vessels in that particular area, and it gives that hemostatic effect that we really need. Now, this hemostatic effect is not permanent, and usually the vasculature returns to normal in a very little amount of time. And really kind of depends on how high the local levels of epinephrine are and how quickly they decrease. Now, epinephrine is a potent bronchodilator due to its beta-2 effects on bronchial smooth muscle. And naturally, it is an important drug to have in your emergency kit for the management of severe bronchospasms or a severe asthma attack, such as status asthmaticus. CNS, at normal doses, it has really no effect on the CNS, but CNS actions can occur at excessive doses. Now, epinephrine stimulates glycogenolysis, and that elevates blood glucose, and it also increases oxygen consumption in all tissues. Now, here we have some side effects of epinephrine, which you can read on the screen, but let me direct your attention to some of the specific uses of epinephrine on the other side of the screen, other than as a vasoconstrictor in dentistry. It's used in anaphylactic shock in the form of an EpiPen. It's used for status asthmaticus. It's used for cardiac arrest to help get the heart jump-started again. It's used as a hemostatic agent as well as used to dilate the pupils. So when we talk about maximum doses, we consider both the healthy and the cardiovascularly compromised patient. And when doing so, we want to provide the most effective anesthesia while limiting the patient's exposure to high concentrations of epinephrine. Now, of particular importance is the limitation or even the complete avoidance of epinephrine exposure in the cardiovascularly compromised patient. So in particular, some ASA3 and ASA4 patients may require special consideration when you're administering local anesthetics containing epinephrine. Overall, though, the risk of administering epinephrine ultimately has to be weighed against the benefits. Well, what does that mean? Well, let's say that you have a patient that comes in as an emergency with severe pain on tooth number 19, which is on the lower left. Their blood pressure is 172 over 105. And the question comes, do you administer anesthetic with epinephrine or without epinephrine? What are the benefits of using anesthetic with epinephrine? Do those benefits outweigh the risk of elevating the patient's blood pressure? Well, here's some guidance. The majority of epinephrine containing local anesthetic that we use in the clinic carry a concentration of 1 to 100,000. That really translates to about 18 micrograms per cartridge. Now, for a normal, healthy patient, that's typically an ASA1 or even an ASA2, a maximum dose of 0.2 milligrams or 200 micrograms per appointment is perfectly acceptable. For patients with significant cardiovascular disease who are an ASA3 or 4, a maximum dose of 0.04 milligrams or 40 micrograms is recommended. Now remember, look at these numbers. For a cardiovascularly compromised patient, maximum dose of 40 micrograms is recommended. We know that there are 18 micrograms per cartridge. So that would mean that 2 cartridges would be 36 micrograms, or just below that 40 microgram recommendation. So that means that for a cardiovascularly compromised patient, you want to limit their exposure to epinephrine at a concentration of 1 to 100,000 to 2 carpules. So, as I mentioned before, adding a vasoconstrictor to a local anesthetic solution prolongs the duration and depth of anesthesia. And this table shows some typical duration times for local anesthetics at different concentrations of epinephrine. And you can look over this table on your own to see the relationship between the duration of action and the concentration of epinephrine. Generally speaking, though, the duration of action gets longer when you add local anesthetic or when you add epinephrine to the local anesthetic. Here are a few items that we need to know about the patient to assess the risk of administering an epinephrine containing local anesthetic. I'm sorry. So let me repeat that. We have a few items here that we need to know about the patient to assess the risk of administering a local anesthetic that has epinephrine in it. But let me direct your attention to the right side of the screen. The risk assessment for someone, if you're going to give them a local anesthetic that has epinephrine, the risk assessment for someone who has had damage due to an acute myocardial infarction is very high. The same goes for a person who has angina or chest pain at rest. Those who have dysrhythmias with refraction, also very high risk. People who have hyperthyroid, also a very high risk. And those who are on MAOIs or monoamine oxidase inhibitors or TCAs or tricyclic antidepressants also have a moderate risk associated with them. So it's important to know that you need to really follow up with anything that might raise any red flags on the patient's questionnaire during your patient interview or by your visual evaluation of the patient as well. So in conclusion, the addition of epinephrine to local anesthetics results in the following benefits. You have a slower rate of systemic absorption, a lower systemic blood level, you have prolonged duration of anesthesia, more profound anesthesia, and also a lower risk of systemic toxicity. Now this concludes lecture 2 for local anesthesia. And if you have any questions, please feel free to let me know. And I'm always available to you. Email is probably best, and you can email me at ae.varela@hsc.utah.edu. Thank you very much.